Good evening. Thank you to the organizers for inviting me as the sole EP speaker. I'll be talking about pulse field ablation. Is it a hype cycle or a next great hope in the arrhythmia care? As you all know by now, pulse field ablation PFA has kind of taken over the EP community in a big storm. The usage has skyrocketed in the last year or so. So let me go forward. All right, so when we talk about traditional ablation, cardiac ablation, we are talking about radiofrequency and cryoablation. And both those technologies use thermal energy, either very hot or very cold catheters to cause localized strategic damage to achieve the desired effect. But because the thermal energy is not very well controlled, it can cause collateral damage. And we see that with radiofrequency and also with cryoablation that very close structures like the esophagus or the phrenic nerve can get damaged. So that's where the interest in pulse field ablation came about, because pulse field ablation came with the hope and promise of very, very safe technology as opposed to thermal ablation. So pulse field ablation is based on the concept of electroporation. Electroporation is when an electrical field, a very high electrical field, is applied to living cells. The cell membranes develop tiny, small nanopores. And depending upon the strength of the electrical field, this can cause a reversible electroporation in which the cells will leak contents but that they won't die. Or if the electrical field strength is fairly high, it will cause irreversible electroporation, which will lead to eventual cell death. And if the electrical field is increased in intensity and pulse width more, it will eventually cause more thermal damage also. So that's the concept behind pulse field ablation. Another major benefit of pulse field ablation when this technology was being developed was the fact that different tissues have different selectivity to the effect of electroporation. And it turned out that myocardial cells are very sensitive to electroporation effect, while nerve cells and esophagus seem to be fairly resistant. At least that was what was in animal studies and bench testing showed us. So that was the promise of pulse field ablation. This is another schematic showing how pulse field ablation works. You have the cell membrane, you apply the electrical field, it causes mini pores to form, and then eventually it results in cell death. One of the problems so far with pulse field ablation has been that it's not standardized, as opposed to radiofrequency ablation and cryoablations, which have been around for a long time. Catheters and the energy source are all fairly standardized. In pulse field ablation, we have different shapes of catheters and sizes. We have different protocols, how the energy is applied. We have different energy strengths being used in different generators. So there's no particular standard for PFA yet. I think that as time goes by and we understand this technology better, there will be move towards a little bit more standardization. So right now, commercially available catheters are these four catheters. The FeraPulse from Boston Scientific is a catheter which can change in shape. It can be made into a basket catheter or a flower-shaped catheter, and it delivers electrical field in a bipolar and biphasic waveform. This is probably the most highly used and one of the most used catheters right now in practice. Medtronic was the first one which came out, the PFA catheter, the Medtronic Pulse Select. It was a kind of a lasso catheter. And then Medtronic came out with the Affera catheter, which is the second one. This catheter is special in the sense that it can apply both PFA and RFA from the same catheter. So that's the unique feature of this catheter. And then Biosense Webster have a catheter called the VeraPulse, which is also a lasso catheter with 10 poles. All of these catheters deliver energy in a bipolar, biphasic waveform, but they have different strengths, and the lesion size and things are different. This slide, I've summarized all the published large-scale human data, and as you can see, there have been a lot of large studies looking at safety and efficacy of PFA. Most of them have been observational, multi-center studies, but there have been a few randomized control trials comparing PFA head-to-head with either radiofrequency ablation or cryoablation. But one thing which stands out in all of these trials is that the acute success rate of achieving pulmonary vein electrical isolation is very high with PFA. And the safety when it comes to injury to the esophagus or injury to the surrounding contiguous structures has been very, very low. So in those terms, the initial data in humans for PFA looks very promising. And basically based on this data, it has led to an explosion of use of PFA in AFib. So let me show you a little bit more granular data from, this is basically a meta-analysis comparing PFA versus both RFA and cryo. And as you can see that even though it's a new technology, because of the catheter's shape and size, you can cover a large area. It results in less procedure time. So what we have seen is that the time for AFib ablation has gone down significantly because of PFA. On the other hand, with RFA, we were going mostly not using any fluoro, but with PFA, pulse field ablation, there has been an uptick in the use of X-ray. And as you can see, most of the trials show that even in operators who use X-ray for radiofrequency ablation, even they tend to use more X-ray. So there's more X-ray exposure. In terms of complications, it pretty much shows the same data as the randomized trials have shown that safety-wise, it's about as good as the traditional ablation technologies are. Slightly safer, but the difference is not significant. And the same thing stands for the short-term and long-term recurrence of atrial arrhythmias. Seems to be as effective at 6 months and 1 year in achieving sinus rhythm. Now, looking at data from large randomized trials is different. Once the technology gets released into the community and people start using it in ways it was not approved for, then you start seeing new complications emerge. So that's the same with PFA technology also. So we are starting to see reports come out, small reports of different types of complications which were not seen in the randomized trials. So this is a report from a European group. What they did was they took a special catheter to actually measure the action potential of the diaphragm. And the idea was that PFA is supposed to be very safe and do not cause phrenic nerve injury. But when they looked at the actual action potential of the diaphragmatic muscle, they find that there was a fairly high incidence of subclinical decrease in the action potential amplitude, suggesting that we are actually causing some subclinical phrenic nerve damage. Most of the time it's reversible, it recovers, but there were a few cases in this series in which the patients, even at 6 months, had a slight phrenic nerve damage. So that's something to keep in mind. Another thing which has come out over the years, over the last few months, is that with PFA we are seeing Turn it off. Hello? All right, okay, it's back. And the hemolysis seems to be more when your catheter is not in contact with the tissue. This is in vitro study showing that as the number of applications increase, the hemolysis increases, and if you're not in good contact with the tissue, if the catheter is floating in the blood pool, you tend to get more hemolysis. This is an animal study showing the same thing, that as the number of applications increase, you get more and more hemolysis. Now, this can become clinically significant. There have been case reports of people developing acute renal failure from the hemolysis from PFA. So people have looked into it, and they have come up with ways to try and prevent this problem from happening in the first place. So one of the ideas is if you hydrate the patient during or before the procedure, you can blunt the damage from hemolysis. And this group showed that if you either pre-treat them or even during the procedure, if you give them a lot of fluids, the hemolysis does not cause acute kidney injury. Another complications which has now been seen in many different cases is coronary artery spasm, which happens typically in two different locations in the atria, one over the mitral isthmus, the other over the cavotricuspid isthmus. So if you are delivering PFA over the mitral isthmus, you can get spasm of the circumflex, and over the cavotricuspid isthmus, you can get spasm of the right coronary artery. Most of the time, these are subclinical. They do not cause ECG changes, don't cause troponin leaks or chest pain, but once in a while, it can be problematic. So in this case report, they show that if you deliver lesion higher up towards the superior aspect, towards the base of the appendage, you tend to get more spasm. If you go down towards the lower end of the mitral isthmus, there tend to be less spasm. So this slide basically summarizes all the different issues, and this is the conclusions. So overall, I think PFA holds a lot of promise. It seems to be fairly effective, also seems to be fairly safe. For sure, there is no damage to the esophagus, there is no pulmonary vein stenosis, but we have to look more into the hemolysis and the phrenic nerve injury and coronary spasm as we use more and more of this technology. Thank you.